Hello, my name is Diwakar Davar, and I'm welcoming you to the ASCO Daily News Podcast. I'm an associate professor of medicine and the clinical director of the Melanoma and Skin Cancer Program at the University of Pittsburgh's Hillman Cancer Center. Today, I'm joined by my colleague and good friend, Dr. Jason Luke. Dr. Luke is a professor of medicine. He is also the associate director of clinical research and the director of the Phase 1 IDDC Program at the University of Pittsburgh's Hillman Cancer Center. He and I are going to be discussing some key advancements in melanoma and skin cancers that were presented at the 2025 ASCO Annual Meeting. Our full disclosures are available in the transcript of this episode. Jason, it is great to have you back on the podcast.
Thanks so much for the opportunity, and I'm really looking forward to it.
Perfect. So we will go ahead and start talking a little bit about a couple of key abstracts in both the drug development, immunotherapy space, and the melanoma space. The first couple of abstracts, the first two will cover melanoma. So the first is LBA 9500, which was essentially the primary results of Relativity 098. Relativity 098 was a phase 3 trial that compared nivolumab plus relatlimab in a fixed dose combination against nivolumab alone for the adjuvant treatment of resected high-risk disease. Jason, do you want to maybe give us a brief context of what this is?
Yeah, it's great. Thanks. So as almost all listeners, of course, will be aware, the use of anti-PD-1 immunotherapy has really revolutionized melanoma oncology over the last 10 to 15 years, and it has become a standard of care in the adjuvant setting as well. But to review, in patients with stage 3 melanoma, treatment can be targeted towards BRAF with BRAF and MEK combination therapy where that's relevant, or anti-PD-1 with nivolumab or pembrolizumab are a standard of care. And more recently, we've had the development of neoadjuvant approaches for palpable stage 3 disease. And in that space, if patients present based on two different studies, either pembrolizumab or nivolumab plus ipilimumab can be given prior to surgery for somewhere in the 6 to 9 week range. And so all of these therapies have improved time to event endpoints such as relapse-free or event-free survival. It's worth noting, however, that despite those advances, we've had a couple different trials now that have actually failed in this adjuvant setting, most high profile being the Checkpoint 915 study, which looked at nivolumab plus ipilimumab, and unfortunately was a negative study. So with Relativity 047, which was the trial of nivolumab plus relatlimab that showed an improvement in progression-free survival for metastatic disease, there's a lot of interest, and we've been awaiting these data for a long time for Relativity 098, which of course is this adjuvant trial of LAG-3 blockade with relatlimab plus nivolumab.
Great. So with that, let's briefly discuss the trial design and the results. So this was a randomized phase 3 blinded study, so double-blinded. So neither the investigators knew what the patients were getting, nor did the patients know what they were getting. The treatment investigational arm was nivolumab plus relatlimab in the fixed dose combination. So that's the Nivo standard fixed dose with relatlimab that was FDA approved in 047. And the control arm was nivolumab by itself. The duration of treatment was 1 year. The patient population consisted of resected, high-risk stage 3 or 4 patients. The primary endpoint was investigator-assessed RFS, stage, and geography with standard stratifying factors. They were included, and most of the criteria were balanced across both arms. What we know at this point is that the 2-year RFS rate was 64% and 62% in the Nivo and Nivo combination arms, respectively. The 2-year DMFS rate was similarly equivalent, 76% with Nivo monotherapy, 73% with the combination. And similar to what you were talked about with Checkmate 915, unfortunately, the addition of LAG-3 did not appear to improve the RFS or DMFS compared to control in this patient population. So tell us a little bit about your take on this and what do you think might be the reasons why this trial was negative?
It's really unfortunate that we have this negative phase 3 trial. There had been a lot of hope that the combination of nivolumab with relatlimab would be a better tolerated combination that increased the efficacy. So in the metastatic setting, we do have 047, the study that demonstrated nivolumab plus relatlimab, but now we have this negative trial in the adjuvant setting. And so as to why exactly, I think is a complicated scenario. You know, when we look at the hazard ratios for relapse-free survival, the primary endpoint, as well as the secondary endpoints for distant metastasis-free survival, we see that the hazard ratio is approximately 1. So there's basically no difference. And that really suggests that relatlimab in this setting had no impact whatsoever on therapeutic outcomes in terms of efficacy. Now, it's worth noting that there was a biomarker sub-analysis that was presented in conjunction with these data that looked at some immunophenotyping, both from circulating T cells, CD8 T cells, as well as from the tumor microenvironment from patients who were treated, both in the previous metastatic trial, the Relativity 047 study, and now in this adjuvant study in the Relativity 098 study. And to briefly summarize those, what was identified was that T cells in advanced melanoma seem to have higher expression levels of LAG3 relative to T cells that are circulating in patients that are in the adjuvant setting. In addition to that, there was a suggestion that the magnitude of increase is greater in the advanced setting versus adjuvant. And the overall summary of this is that the suggested rationale for why this was a negative trial may have been that the target of LAG3 is not expressed as highly in the adjuvant setting as it is in the metastatic setting. And so while the data that were presented, I think, support this kind of an idea, I am a little bit cautious that this is actually the reason for why the trial was negative, however. I would say we were not really sure yet as to why the trial was negative, but the fact that the hazard ratios for the major endpoints were essentially 1 suggests that there was no impact whatsoever from relatlimab. And this really makes one wonder whether or not building on anti-PD-1 in the adjuvant setting is feasible because anti-PD-1 works so well. You would think that even if the levels of LAG3 expression were slightly different, you would have seen a trend in one direction or another by adding a second drug, relatlimab, in this scenario. So overall, I think it's an unfortunate circumstance that the trial is negative. Clearly, there's going to be no role for relatlimab in the adjuvant setting. I think this really makes one wonder about the utility of LAG3 blockade and how powerful it really can be. I think it's probably worth pointing out there's another adjuvant trial ongoing now of a different PD-1 and LAG3 combination, and that's cemiplimab plus fianlimab, a LAG3 antibody that's being dosed from another trial sponsor at a much higher dose. And perhaps that may make some level of difference. But certainly these are unfortunate results that will not advance the field beyond where we were at already.
And to your point about third generation checkpoint that were negative, I guess it's probably worth noting that a trial that you were involved with, KeyVibe-10, that evaluated the PD-1 TIGIT co-formulation of vibostolimab, MK4280A, was also unfortunately similarly negative. So to your point, it's not clear that all these third generation receptors are necessarily going to have the same impact in the adjuvant setting, even if they, for example, like TIGIT, and they sometimes may not even have an impact at all in the advanced cancer setting. So we'll see what the Harmony phase 3 trial, that's the Regeneron semi-FIAN versus Pembro control with with FIAN at 2 different doses. We'll see how that reads out. But certainly, as you've said, LAG3 does not, unfortunately, appear to have an impact in the adjuvant setting. So let's move on to LBA 9501. This is the primary analysis of EORT-2139mg, or the Columbus AD trial. This was a randomized trial of encorafenib and binimetinib, which we will abbreviate as ENCOBINI going forward, compared to placebo in the high-risk stage 2 setting in melanoma in patients with BRAF V600E or K mutant disease. So Jason, you happen to know one or two things about the resected stage 2 setting. So maybe contextualize the stage 2 setting for us based on the trials that you've led, Keynote 716, as well as Checkmate 76K, set us up to talk about Columbus AD.
Thanks for that introduction. And certainly stage 2 disease has been something I've worked a lot on. The rationale for that has been that building off of the activity of anti-PD-1 in metastatic melanoma, and then seeing the activity in stage 3, like we just talked about, it was a curious circumstance that dating back about 7 to 8 years ago, there was no availability to use anti-PD-1 for high-risk stage 2 patients, even though the risk of recurrence and death from melanoma in the context of stage 2B and 2C melanoma is in fact similar or actually higher than in stage 3A or 3B, where anti-PD-1 was approved. And in that context, a couple of different trials that you alluded to, the Keynote 716 study that I led, as well as the Checkmate 76K trial, evaluated pembrolizumab and nivolumab respectively, showing an improvement in relapse-free and distant metastasis-free survival. And both of those agents have subsequently been approved for use in the adjuvant setting by the US FDA, as well as the European Medicines Agency. So bringing them to this abstract, throughout melanoma oncology, we've seen that the impact of anti-PD-1 immunotherapy versus BRAF and MEK targeted therapy have had very similar outcomes on a sort of comparison basis, both in frontline metastatic and then in adjuvant setting. So it was a totally reasonable question to ask, could we use adjuvant BRAF and MEK inhibitor therapy? And I think all of us expected the answer would be yes. As we get into the discussion of the trial, I think the unfortunate circumstance was that the timing of this clinical trial being delayed somewhat, unfortunately, made it very difficult to accrue the trial. And so we're going to have to try to read through the tea leaves sort of based on only a partially complete data set.
So in terms of the results, they wanted to enroll 815 patients. They only enrolled 110. The RFS and DMFS were marginally improved in the treatment arm, but certainly not significantly, which is not surprising because the trial had only accrued 16 to 18% of its complete accrual. As such, we really can't abstract from the stage 3 Combi-AD data of stage 2 patients. And certainly in this setting, one would argue that the primary treatment options certainly remain either anti-PD-1 monotherapy, either with Pembro or Nivo based on 716 or 76K, or potentially active surveillance for the patients who are not inclined to get treated. Can you tell us a little bit about how you foresee drug development going forward in this space? Because, for example, with Harmony, certainly 2C disease is a part of Harmony. We will know at least a little bit about that in this space. So what do you think about the stage 2 BC patient population? Is this a patient population in which future combinations are going to be helpful? And how do you think about where we can go forward from here?
It is an unfortunate circumstance that this trial could not be accrued at the pace that was necessary. I think all of us believe that the results would have been positive if they had been able to accrue the trial. In the preliminary data set that they did disclose of that 110 patients, it's clear there is a difference at a landmark at a year. They showed 16% difference, and that would be in line with what has been seen in stage 3. And so, I think it's really kind of too bad. There's really going to be no regulatory approach for this consideration. So using BRAF and MEK inhibition in stage 2 is not going to be part of standard practice moving into the future. To your point, though, about where will the field go, I think what we're already realizing is that in the adjuvant setting, we're really over-treating the total population. And so beyond merely staging by AJCC criteria, we need to move to biomarker selection to help inform which patients truly need the treatment. And in that regard, I don't think we've crystallized together as a field as yet, but the kinds of things that people are thinking about are the integration of molecular biomarkers like ctDNA. When it's positive, it can be very helpful. But in melanoma, we found that unfortunately the rates are quite low, in the 10 to 15% range in the adjuvant setting. So then another consideration would be factors in the primary tumor, such as gene expression profiling or other considerations. And so I think the future of adjuvant clinical trials will be an integration of both the standard AJCC staging system, as well as some kind of overlaid molecular biomarker that helps to enrich for a higher risk population of patients. Because on a high level, when you abstract out, it's just clearly the case that we're rather substantially over-treating the totality of the population, especially given that in all of our adjuvant studies to date, for anti-PD-1, we have not yet shown that there's an overall survival advantage. And so some are even arguing perhaps we should even reserve treatment until patients progress. I think that's a complicated subject, and standard of care at this point is to offer adjuvant therapy, but certainly a lot more to do because many patients, unfortunately still do progress and move on to metastatic disease.
Let's transition to abstract 2508. So we're moving on from the melanoma to the novel immunotherapy abstracts. And this is a very, very, very fascinating drug. It's IMA203. So abstract 2508 is the phase 1 clinical update of IMA203. IMA203 is an autologous TCR-T construct targeting PRAME in patients with heavily pretreated PD-1 refractory metastatic melanoma. So Jason, in the PD-1 and CTLA-4 refractory settings, treatment options are either autologous TIL, response rate, ballpark 29 to 31%, oncolytic viral therapy, RP1 with nivolumab, ORR about 30-ish%. So new options are needed. Can you tell us a little bit about IMA203? Perhaps tell us, for the audience, what is the difference between a TCR-T and traditional autologous TIL, and a little bit about this drug, IMA203, and how it distinguishes itself from the competing TIL products in the landscape.
I'm extremely enthusiastic about IMA203. I think that it really has transformative potential based on these results and hopefully from the phase 3 trial that's open to accrual now. So what is IMA203? We said it's a TCR T cell product. So what that means is that T cells are removed from a patient, and then they can be transduced through various technologies, but inserted into those T cells, we can then add a T cell receptor that's very specific to a single antigen. In this case, it's PRAME. So that then is contrast quite a bit from the TIL process, which includes a surgical resection of a tumor where T cells are removed, but they're not specific necessarily to the cancer, and they're grown up in the lab and then given to the patient. They're both adoptive cell transfer products, but they're very different. One is genetically modified and the other one is not. And so the process for generating a TCR T cell is that patients are required to have a new biomarker that some may not be familiar with, which is HLA profiling. So the T cell receptor requires matching to the concomitant HLA for which the peptide is bound in. And so the classic one that is used in most oncology practices is A201, because approximately 48% of Caucasians have A201, and the frequency of HLA in other ethnicities starts to become highly variable. But in patients who are identified to have A201 genotype, we can then remove blood via leukapheresis or an apheresis product, and then insert via lentiviral transduction this T cell receptor targeting PRAME. Patients are then brought back to the hospital where they can receive lymphodepleting chemotherapy and then receive the reinfusion of the TCR T cells. Again, in contrast with the TIL process, however, these T cells are extremely potent, and we do not need to give high-dose interleukin-2, which is administered in the context of TIL. Given that process, we have this clinical trial in front of us now, and at ASCO, the update was from the phase 1 study, which was looking at IMA203 in an efficacy population of melanoma patients who were refractory to checkpoint blockade and actually multiple lines of therapy. So here there were 33 patients, and a response rate of approximately 50% was observed in this population of patients, notably with a duration of response approximately a year in that treatment group. And I realized that these were heavily pretreated patients who had a range of very high-risk features, and approximately half the population had uveal melanoma, which people may be aware is a generally speaking, more difficult to treat subtype of melanoma that metastasizes to the liver, which again has been a site of resistance to cancer immunotherapy. So these results are extremely promising. To summarize them from what I said, it's easier to make TCR T cells because we can remove blood from the patient to transduce the T cells. We don't have to put them through surgery. We can then infuse them, and based on these results, it looks like the response rate to IMA203 is a little bit more than double what we expect from lifileucel. And then, whereas with lifileucel or TILs, we have to give high-dose IL-2, here we do not have to give high-dose IL-2. And so that's pretty promising. And a clinical trial is ongoing now called the SUPREME phase 3 clinical trial, which is hoping to validate these results in a randomized global study.
Now, one thing that I wanted to go over with you, because you know this trial particularly well, is what do you think of the likelihood of success? And then we'll talk a little bit about the trial design. But in your mind, do you think that this is a trial that has got a reasonable likelihood of success, maybe even a high likelihood of success? And maybe let's contextualize that to say a alternative trial, such as, for example, the TEBI-AM trial, which is essentially a T cell bispecific targeting GP100. It's being compared against SOC, investigator's choice control, also a similarly heavily pretreated patient population.
So both trials, I think, have a strong chance of success. They are very different kinds of agents. And so the CD3 bispecific that you referred to, tebentafusp, likely has an effect of delaying progression, which in patients with advanced disease could have a value that might manifest as overall survival. With TCR T cells, by contrast, we see a very high response rate, with some of the patients going into very durable long-term benefit. And so I do think that the SUPREME clinical trial has a very high chance of success. It will be the first clinical trial in solid tumor oncology randomizing patients to receive a cell therapy as compared with a standard of care. And within that standard of care control arm, TILs are allowed as a treatment. And so it will also be the first study that will compare TCR T cells against TILs in a randomized phase 3. But going back to the data that we've seen in the phase 1 trial, what we observe is that the duration of response is really connected to the quality of the response, meaning if you have more than a 50% tumor shrinkage, those patients do very, very well. But even in patients who have less than 50% tumor shrinkage, the median progression-free survival right now is about 4.5 months. And again, as we think about trial design, standard of care options for patients who are in this situation are unfortunately very bad. And the progression-free survival in that population is probably more than like 2 months. So this is a trial that has a very high likelihood of being positive because the possibility of long-term response is there. But even for patients who don't get a durable response, they're likely going to benefit more than they would have based on standard chemotherapy or retreatment with an anti-PD-1 agent.
Clearly a very important trial to enroll, a trial that is first in many ways, first of a new generation of TCR-T agents, first trial to look at cell therapy in the control arm, a new standard of efficacy, but potentially also if this trial is successful, it'll also be a new standard of trial conduct, a new kind of trial of a set of trials that will be done in the second-line immunotherapy refractory space. So let's pivot to the last trial that we were going to discuss, which was Abstract 2501. Abstract 2501 is a first-in-human phase 1/2 trial evaluating BNT142, which is the first-in-class mRNA encoded bispecific targeting Claudin-6 and CD3 in patients with Claudin-positive tumors. We'll talk a little bit about this, but maybe let's start by talking a little bit about Claudin-6. So Claudin-6 is a very interesting new target. It's a target that's highly expressed in GI and ovarian tumors. There are a whole plethora of Claudin-6 targeting agents, including T-cell bispecifics and Claudin-6-directed CAR-Ts that are being developed. But BNT142 is novel. It's a novel lipid nanoparticle, LNP encapsulated mRNA. The mRNA encodes an anti-Claudin-6 CD3 bispecific termed RiboMab021, and it then is administered to the patient. The BNT142 encoding mRNA LNPs are taken up by the liver and translated into the active drug. So Jason, tell us a little bit about this agent, why you think it's novel, if you think it's novel, and let's talk a little bit then about the results.
So I certainly think this is a novel agent, and I think this is just the first of what will probably become a new paradigm in oncology drug development. And so you alluded to this, but just to rehash it quickly, the drug is encoded as genetic information that's placed in a lipid nanoparticle and then is infused into the patient. And after the lipid nanoparticles are taken up by the liver, which is the most common place that LNPs are usually taken up, that genetic material in the mRNA starts to be translated into an actual protein, and that protein is the drug. So this is in vivo generation. So the patient is making their own drug inside their body. I think it's a really, really interesting approach. So for any drug that could be encoded as a genetic sequence, and in this case, it's a bispecific, as you mentioned, CD3 Claudin-6 engager, this could have a tremendous impact on how we think about pharmacology and novel drug development moving into the future in oncology. So I think it's an extremely interesting drug, the like of which we'll probably see only more moving forward.
Let's maybe briefly talk about the results. So, the patient population was heavily pretreated, 65 or so patients, mostly ovarian cancer. 2/3 of the patients were ovarian cancer. The rest were germ cell and lung cancer patients. But let's talk a little bit about the efficacy. The disease control rate was about 58% and in the phase 1 population as a whole, but 75% in the ovarian patient population. Now, tell us a little bit about the interesting things about the drug in terms of the pharmacokinetics, and also then maybe we could pivot to the clinical activity by dose level.
Well, so they did present in their presentation at ASCO a proportionality showing that as higher doses were administered, that greater amounts of the drug was being made inside the patient. And so that's an interesting observation, and it's an important one, right? Suggesting that the pharmacology that we classically think of by administering drugs by IV, for example, would still be in play. And that did translate into some level of efficacy, particularly at the higher dose levels. Now, the caveat that I'll make a note of is that disease control rate is an endpoint that I think we have to be careful about, because what that really means is sometimes a little bit unclear. Sometimes patients have slowly growing tumors and so on and so forth. And the clinical relevance of disease control, if it doesn't last at least 6 months, I think is probably pretty questionable. So I think these are extremely interesting data, and there's some preliminary sense that getting the dose up is going to matter because the treatment responses were mostly observed at the highest dose levels. There's also a caveat, however, that across the field of CD3 bispecific molecules like this, there's been quite a bit of heterogeneity in terms of the response rate. with some of them only really generating stable disease responses and other ones having more robust responses. And so I think this is a really interesting initial foray into this space. My best understanding is this molecule is not moving forward further after this, but I think that this really does set it up to be able to chase after multiple different drug targets on a CD3 bispecific backbone, both in ovarian cancer, but then basically across all of oncology.
Perfect. This is a very new sort of exciting arena where we're going to be looking at, in many ways, these programmable constructs, whether we're looking at in vivo generated, in this case, the T-cell bispecific, but we've also got newer drugs where we are essentially giving drugs where people are generating in vivo CAR T and also potentially even in vivo TCR-T. But certainly lots of new excitement around this entire class of drugs. And so what we'd like to do at this point in time is switch to essentially the fact that we've got a very, very exciting set of data at ASCO 2025. You've heard from Dr. Luke regarding the advances in both early drug development, but also in advanced cutaneous melanoma. And Jason, as always, thank you so much for sharing your very valuable and great, fantastic insights with us on the ASCO Daily News Podcast.
Well, thanks again for the opportunity.
And thank you to our listeners for taking your time to listen today. You will find the links to the abstracts that were discussed today in the transcript of this episode. And finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.